So today we're joined with Dr. Roy Geronemus. Thank you for joining us today, Dr. Geronemus. I appreciate your time very much.
My pleasure.
And we're going to review real quickly the ocular eye shields. First off, how long have you been using the ocular eye shields for laser treatment?
I hate to say it, but 40 years. So I've got a lot of experience with eye shields.
Yeah, you sure do at that. And tell me about the patient demographic. Which patients do you use shields on?
Well, I do a lot of birthmark work, so that's the bulk of what I do with eye shields. We begin during early infancy, including newborns, which I think is a major benefit to these patients, all the way up to people in their 80s and 90s coming in for cosmetic procedures. So a very wide range, and we're putting shields in all day long. So a lot for birthmarks, a lot for cosmetic work. We do a lot of laser work around the eyes. We really find them extremely useful and imperative to use for patient safety.
Absolutely. And if you don't mind, just a little bit of information for people that aren't using them. As far as numbing the eye and, putting lubricant in, do you numb the eye and do you use a lubricant as well?
So we do numb the eye anytime we put an ocular shield in. I think it's imperative for patient comfort. It works instantaneously. So there are different topical anesthetics that one can use. The most commonly used one is tetracaine, but there are others as well that can be used safely and effectively. The tetracaine does burn a little bit, and there are others that are kept refrigerated that don't burn as much, but that burning sensation goes away very quickly. I do put in some lubrication. I use different products that are very helpful in protecting the eye, particularly in the older patient. And that's important because some of the older patients may have corneal issues. So putting a shield on them they're more prone to a corneal abrasion, which is something you want to avoid at all costs. That's why one reason it's important to have a company like yours that makes great eye shields, because we don't want scratches on the eye shields. But some patients, regardless of whether the shield is perfectly placed and the shield itself is in perfect condition, are more prone to an abrasion. So particularly in those patients, when we do laser resurfacing with an ablative laser, we're much more inclined to put in a protective lubrication inside the shield itself or placing it on the eye.
Yeah, fantastic. Thank you. As far as sizing these things for the patient, I know that's a question that I get a lot of, is which size do I need? Which size do I not need? Do you have any suggestions or tips when figuring out what size to use for patients?
So the pediatric shields that you just made, which fills a tremendous void in the laser community, because there was no such thing. The previous companies had abandoned manufacturing. So the fact that you've done that is terrific. And I think the word's getting out. I hope so at least. And so the newborns, I think they were 16 millimeters. Is that correct?
That's right. Yep.
So we're using that for the newborns, and the baby's eyes grow relatively quickly. So those pediatric 16 millimeter shields, are good for a few months, maybe 2 or 3 months at max. And then we graduate to a larger shield. So you get a pretty good sense, when you're treating a patient as to whether you've sized it correctly. Sometimes you can actually see the white of the eye. And if it doesn't cover enough, so then you've got to size up. So we keep a range of sizes available, keeping in mind that we often have to change the sizes as the patient ages.
Absolutely.
Larger shields for the adults routinely.
Yeah, and we make a 16, a 20, and a 24 millimeter. And as you said, the size actually goes up pretty quickly. I was kind of surprised when I was in your office, just how quickly that the size of the eye does develop.
Yeah, we could probably use an 18.
If you need it, we'll do it.
Okay. No, I've got
Not a problem.
A patient right now who was asking me just the other day, because she's right in between the 16 and 20, because I put a 20 in and it was a little too much and the 16 was too small. So
Now we've got 16, 20, and 24. Do you think you need a 22 as well?
I'm not sure. Let me look at that again. Possibly.
Okay.
Possibly.
Okay. We can, once we build these molds, we can make any sizes that's
Oh,
necessary.
that's great.
Yeah,
No, I
definitely
think
not
it's
a problem.
great thing to have.
Yeah, and obviously the ocular shields, anybody doesn't know, has a sandblasted exterior to diffuse the laser beam and a very polished interior so that to not cause corneal abrasions, which we already discussed. And obviously our version has a post on it. And I know that after watching you in the procedure room is that you have a very, obviously you've been doing this so long, technique for using this post to get it into the eye. Could you explain that real quick?
Yes. So it's an important technique because it makes a huge difference. And I really don't understand why so many physicians are adverse to putting in eye shields. I think once you learn, it should be quite simple. But I see a lot of patients who come to me just because I put eye shields in, and their other doctors don't. So, and you're eliminating the treatment of an important area. So one of the important things is that the upper eyelid has more space, for the shield. So what I do after I administer the topical anesthetic, I actually lift the upper eyelid up. I place the shield upward and then pull the lower lid down, and that facilitates the remainder of the shield placement.
Absolutely.
So,
and then when you're taking it out, do you come from the bottom side up as well? So you start at the bottom?
Yeah, the bottom side up.
Okay. Yeah, fantastic.
It's interesting. I have to think about it because it's instinctive. It reminds me of that book, Outliers by Malcolm Gladwell, where he talked to experts on what they do, and they asked these great tennis players how they did their topspin, and most of them could not describe it. It's just instinctive. So I had to think about it for a second.
Yeah, absolutely.
But it's definitely doable, and it should be done more commonly. But
I think your office had a fantastic tip too, which is keeping a little cup on the side to put them in so that they don't fall on the floor, so that they don't hit each other. One individual cup for one stainless steel shield. I thought was a brilliant, simple idea just to make sure that you're protecting them as well.
But that was one of the reasons, not just protection, but what we found is that, we have a surgical tray set up, and we found that the nurses would sometimes throw them away. And as you know, these things aren't cheap, so we don't want to lose them. So it helps us, helps the nurses remember to take them off the tray and clean them.
Perfect. And then cleaning, we have the ability to autoclave or cold sterilize. I know that your office is autoclaving because you've got a whole pack of them all ready to go, but it's, we want to make sure people are cleaning them properly in between patients because obviously, you have to sterilize these in between.
Yeah, and you want to make sure you're not using anything that's caustic to the eye, in terms of, cleansing.
Mm.
So, that can be very irritating.
Absolutely. Very good point. So autoclaving is definitely the direction most people should be going.
I would think so.
Okay, fantastic. Dr. Geronemus, thank you very much for your time. I appreciate everything that you've done for us, and I look forward to speaking with you some more.
Well, as much as I'm doing for you, you've done a lot more for us. So greatly appreciate your company and everything that you're doing because it has made a very big difference in our practice and to all of our patients.
Well, thank you very much. I appreciate that.
And that's not a paid commercial. That's an honest plug there.
Well, there's nothing better than an honest plug. Thank you for that. I appreciate it.
Sure.